Welcome to this clinical teaching session on a child with a changing gait and a potentially treatable movement disorder. This presentation is built around a practical diagnostic challenge: how to recognize key clues in a child who appears at first to have a common gait problem, but whose history points towards something more specific and more treatable. Our goal is not simply to memorize a rare diagnosis. The real goal is to apply bedside reasoning to identify red flags for dopa-responsive dystonia, distinguish it from static conditions such as cerebral palsy, and choose a safe next clinical step. By the end, the key question should be clear. When a child has unexplained dystonia or a changing gait, especially with diurnal variation, could this be a dopamine-sensitive disorder that deserves a supervised levodopa trial? Next slide, please. Let us begin with the clinical story. A 6-year-old girl is referred because of progressive difficulty with walking. She began walking late at around 18 months, and since then she has always seemed clumsy. She falls frequently, especially when she is tired. At first glance, this may sound like a child with mild cerebral palsy or a nonspecific developmental motor problem, but the history contains several important clues. Her symptoms are worse later in the day, and her mother reports that she walks much better in the morning. Her feet turn inward during gait, and she has intermittent stiffening of the right arm while walking or running. At the same time, her cognition is normal. Her strength, reflexes, cranial nerves, and coordination are normal. This combination is important. The abnormality is not simply weakness, ataxia, or spasticity. The pattern suggests a movement disorder, particularly dystonia. The most important clinical message here is that the diagnosis is in the pattern: progressive, fluctuating, and fatigue sensitive. Next slide, please. Now let us focus on the clues that should raise suspicion for dopa-responsive dystonia. The first clue is progression. A child who is getting worse over time should not be casually labeled as having a static motor disorder. The second clue is diurnal fluctuation. When a parent says the child walks better in the morning and worse in the afternoon or evening, that observation deserves careful attention. It may be more valuable than a single normal examination in clinic. The third clue is worsening with exercise or fatigue. This may make the dystonia more obvious later in the day or after activity. The fourth clue is dystonic posturing. In this case, the inward turning of the feet and intermittent arm rigidity are not typical weakness. They are more consistent with abnormal muscle activation and sustained posturing. The fifth clue is preserved cognition and a relatively normal examination between episodes. This can mislead clinicians, but it also supports the possibility of a fluctuating neurotransmitter-related disorder. A practical bedside question is the child better after sleep and worse later in the day? If the answer is yes, the clinician should think carefully about dopamine-responsive dystonia. Next slide, please. This is one of the major diagnostic traps. Cerebral palsy is a static disorder. The functional challenges may become more noticeable as the child grows, but the underlying brain injury or maldevelopment is not progressive. Cerebral palsy also does not classically produce marked morning to evening fluctuation, and a dramatic levodopa response is not expected. In contrast, dopa-responsive dystonia is progressive, fluctuating, and treatable. The gait may worsen later in the day and with fatigue. The dystonic posturing may be intermittent early on. Strength and reflexes may remain normal, especially in the early stages or during a morning examination. This is why the mother's observation is so important. The child is not simply clumsy. Her gait changes with time of day and exertion. That pattern should make us pause before accepting a diagnosis of mild cerebral palsy. In a child like this, missing dopa-responsive dystonia means missing a condition where early treatment can be life-changing. Next slide, please. Now we come to the clinical decision point. The question is asking for the best next step. The options include diagnosing spastic diplegic cerebral palsy and starting physiotherapy only, treating as paroxysmal kinesiogenic dyskinesia, reassuring the family because the morning exam is normal, or starting a supervised levodopa-carbidopa trial while evaluating for secondary causes. The best answer is to start a supervised levodopa-carbidopa trial while continuing evaluation for secondary causes. This is not an impulsive or casual use of levodopa. It is a targeted therapeutic trial based on a persuasive clinical pattern: childhood onset dystonic gait, progression, diurnal fluctuation, fatigue sensitivity, and preserved cognition. At the same time, this does not mean we stop thinking diagnostically. Imaging, metabolic testing, and genetic evaluation can proceed in parallel. The key is that we should not delay a potentially transformative treatment while waiting for every investigation to return. Next slide, please. The reason levodopa can be so effective is that many of these disorders involve impaired dopamine availability in the nigrostriatal system. In classic forms, the problem is often not a fixed structural lesion of the brain. Instead, it is a neurotransmitter synthesis or cofactor pathway problem. This is why the clinical picture may fluctuate and why treatment can lead to dramatic improvement. Several genetic categories are important. GCH1 is associated with tetrahydrobiopterin synthesis and is classically linked to autosomal dominant dopa-responsive dystonia, although rare recessive forms may be more severe. TH involves tyrosine hydroxylase deficiency and may present as classic dopa-responsive dystonia or as a more complex DRD plus phenotype. SPR, or sepiapterin reductase deficiency, may be associated with developmental delay, oculogyric crises, sleep problems, or autonomic symptoms. PTS and QDPR are also related to tetrahydrobiopterin metabolism or recycling, and in those cases, clinicians may need to consider hyperphenylalaninemia and broader treatment beyond levodopa alone. The practical point is that genetics helps refine the diagnosis, but clinical recognition should begin at the bedside. This slide summarizes a safe and practical workflow. First, recognize the pattern, a progressive fluctuating dystonic gait that is worse late in the day or after exertion. Second, repeat the examination strategically. If the history suggests fluctuation, examine the child later in the afternoon or after activity. A normal morning exam may not capture the disorder. Third, start a supervised levodopa trial when the phenotype strongly suggests a dopamine-sensitive dystonia. Use a low dose, titrate carefully, and monitor both functional improvement and adverse effects. Fourth, evaluate for secondary causes in parallel. This may include MRI, metabolic testing, and assessment of phenylalanine or tetrahydrobiopterin pathways when indicated. Fifth, confirm and refine the diagnosis with genetic testing and, in more complex cases, CSF neurotransmitters or pterin studies. Finally, support function. Physiotherapy, occupational therapy, orthoses, school accommodations, and family counseling may all be needed, especially if diagnosis has been delayed. The key principle is simple. Treatment and evaluation can proceed together when the clinical pattern is convincing. Next slide, please. The central lesson is that we should not miss a treatable cause of childhood dystonia. Any child with unexplained dystonia or a changing gait, especially when there is diurnal variation, deserves consideration of a levodopa trial. There are 3 points to remember. First, progression argues against a static diagnosis such as cerebral palsy. Second, diurnal fluctuation is a major diagnostic clue. Third, fatigue or exercise may reveal dystonia that is subtle earlier in the day. The action step is equally important. Start a supervised levodopa-carbidopa trial when the clinical pattern fits, investigate secondary causes in parallel, and document the functional response carefully. Early recognition, a simple therapeutic test, and thoughtful follow-up can lead to major improvement in a child's mobility and quality of life. Next slide, please. Thank you for your attention. This educational presentation is from Professor Mohammadi's teaching archives.